Very much warm welcome to all of you. My name is Hanna Brodda and I'm going to moderate this seminar. We have been talking about personalized medicine today and patient-centered care. Personally, I think this is the most important revolution, actually, ever since we discovered bacteria. Because, for example, did you know that we all does not benefit from eating rye bread? Yet we are all eating this boring bread every morning. We need some certain enzyme to metabolize the rye. So once we really implemented personalized healthcare, we can actually we can have use of that kind of data. We will use all kind of data. We're going to need AI to handle all this data. And I want to ask you a question, how far we are today. Have any of you experienced true patient-centered care? Maybe you have, but precision medicine. Have you experienced precision medicine in Sweden or elsewhere? No, not yet. I think we're using it in some kind of treatment in cancer, for example, but it's not very common yet. We can use it in much more in prevention, and we're going to use it in so many areas, of course. So, and to be able, hi Axel, to be able to actually use all this, of course, we need standards. So, and with me here today, I mean, this is Sweden and healthcare, we need standardization. So, will a European standard for patient-centered healthcare improve the quality of the treatment and the actual meeting for both patient and caregivers? With me here today I have Axel Wolf. You are a professor in nursing and also head of GPCC, right, from Gothenburg University. Yeah, we know you a little bit from earlier seminar today. So, but please take the scene and tell us about the European new standards that you are part of developing.
Great, or have developed. Warm welcome. My name is Axel Wolf. Thank you for the invitation here to talk about the first ever European standard in patient involvement and person-centered care that is active since 2020. And I'm, like you said, I'm a professor and the center director for GPCC, which is one of the leading research centers in the world about person-centered care and the effects of person-centered care. And we were also the organization that initiated the work with the standard, and I will come back to that. Oh, shoot. There. Can you standardize person-centered care? I always get that question. And of course, because I was part of the standard, I would say yes. And I have some also some studies that suggest that also. But what are we standardizing or why? And this is, like I said, this is the first ever technical committee on a European level that worked on standards for person-centered care. And this is the first standard that is out there in all European countries. It's called Patient Involvement in Healthcare Minimum Requirements for Person-Centered Care. That's the minimum requirement. If you go above that, perfect for me, but that is the minimum requirement that you should have in healthcare. There are standards everywhere, mostly in technical products, not so much in services. So that's why it was also a challenge to lead this standard committee. But why did we want to have a standard? Why did the European countries want to have a standard? And this is not an EU standard, it's a standard for European countries. We wanted to standardize care within and between healthcare settings regarding person-centered care. To standardize care between countries, because as an EU citizen, of course, you can also have healthcare in different countries. To define research methodology within and between countries, and that is also important if we want to do research with other countries. Do we talk about the same thing? Standards are internationally agreed by experts, so you cannot buy a standard, so you need to have it in consensus. And this standard took 5 years to develop through consensus. And we heard also other colleagues talking about how long it takes to do such kinds of regulatory things, like a law, for example. The standard stipulates the base level of what to reach, and this is important. The standard says what we want to reach. The organization and the healthcare provider will say how they reach the standard. We don't say how you should do it. It's just what. So that's an important aspect. And I think a standard is a tool for quality improvement. So it's not about benchmarking. It's a tool for quality improvement by organizations, but also to support the work required by the Patient Act, the Svenska Patientlagen. And in Sweden, we have a patient law, and we know that we aren't complying to the patient law. And the standard may be a tool to facilitate that we reach the things that the law is wanting us to do. So here just see that SIS is the Swedish Institute of Standardization. Then you have a European umbrella organization for all European countries called CEN, and this is a CEN standard. And then you have the global standard, which is called the ISO, and we are talking about the CEN standard. So goals want to create a European platform for person-centered care, and the first standard is the standard I'm talking about right now, about the minimum requirements for patient involvement. We want to influence structures and processes to benefit the patients and healthcare service. So it's not only about the patient, because we have quite a lot of data about the effects on the healthcare organization as well. We, however, didn't aim to standardize the practice of medicine. So guidelines, for example, are guidelines. A standard is below the law in that sense. So it's about optimizing and complementing each other. The challenges is, of course, a controversial area. We are professionally controlled. I am clinicians also. I'm a nurse, so I work in the clinic. So I have both an inside and an outside perspective as a researcher. And different countries have different distance regarding patient involvement, PCC. And we have a nice paper on that. So if you go into the homepage at GPCC, you can read a paper that we did on the European level about that. So this is what I call the Swedish paradox. Sweden is one of the #1 countries, at least if you compare with those here, Denmark, Germany, US, UK, when it comes to medical outcomes. This is pooled data from the OECD and the World Health Organization in the EU from 2017, so it's a little bit old, and we heard about the Paris study or the project that is ongoing. But Sweden is #1 in medical outcome. This is a pooled data from 14 quality indicators, all from mortality after 30 days after myocardial infarction, 5 years survival after breast cancer, infection, so on and so forth. So we are quite good. However, we really suck when it comes to patient participation. We are lost. Even Norway is better. And I'm from Gothenburg, so that really hurts because they are we always compete with Norway. 2 years earlier, this is a study, this is the Commonwealth study. We were at least above Norway, so Norway at last. But now even Norway is ahead of us. That's fine. Then you could also, okay, the paradox is, okay, we have the best medical outcomes compared to those countries, and they differ if you look at different outcomes, but we are quite good at all of them. But we suck in patient participation. Should we then even have patient participation? Or will we a little bit screw up our medical outcomes? There is no data whatsoever, and I have a lot of data from our studies, which are controlled clinical trials, saying that increased person-centered care will reduce medical outcome. We have shown that it will increase medical outcomes. And you can look at other countries that had high medical outcomes that also have high patient participation. So it doesn't really, it's not an either way version of this. So we can do both, and I think that if we increase the patient participation, we will also increase our medical outcomes. And what are the outcomes that we have shown? And this is a paper that we had in the BMG about the controlled trials that we did at the GPCC, but there are other systematic overviews also about the effects. But we have shown reduction in hospital stays by up to 50%, improved discharge process, a reduction of cost, reduced uncertainty in illness, etc., etc. So we have a lot of effects that you can have if you work in a systematical way with person-centered care, and that's what the standard should facilitate. Because it's all about partnership. It's all about the partnership within the care meeting between the patient, I don't know who is the patient here, and the healthcare provider, but also between healthcare providers. So that's why we call it person-centered care and not patient-centered care, because it's about person, and person-centeredness is something that has to do with partnership. It's an ethic, and that you need to have also in your organization in order to... And we have also shown a systematic review by Gustafsson et al. The last year, showing that the work environment increases if we work in a person-centered care approach. However, it is hard to implement. So that's also something that we need to be better at implementing it. But it's about the partnership in both initiating the partnership by the narratives, the stories that the patient tells, but also the healthcare provider, how you work with the partnership, how you co-create a care plan. And I think that's the same if you talk about precision medicine or precision health. In some aspect, you need to do a care plan. So that's why I think that we need to combine person-centered care and precision medicine or precision health. How you document the partnership, which is crucial, because if you don't document the symptoms and the stories of the patient, we can never feed our modern AI models with those kind of data, which is that the only data that we then have is of blood pressure and pulse and ECG, which can, once again, we cannot combine those two then. So we need to be better at also documenting unstructured data. Because it all comes down to this. Some of you will see a young female in this picture, at least if you look at the picture. Some of you will see an old lady in the picture. So here you have the old lady with the chin and the mouth and the nose. Here you have the young female with the nose here and the eye and the ear. The funny thing is that now that you see them, you cannot unsee them. You see both. Almost. The problem is, or this is, Daniel Kahneman received the Nobel Prize for it. You cannot see them both equally well at the exact same time. You shift. That's why you need to have a team. That's why you need to co-create together with the patient, with the physician, with the nurse, with the occupational therapist, with the relatives. You name it. We have different perspectives, even if we talk about the same. So that's why we need to have person-centered care, and we need to have patient-public involvement. However, we have shown that you need to have, if you want to have the most out of it, you need to do it systematically all the time, every day, at every meeting. You cannot have an on-off switch in that sense. So you need to have some sort of structure. Here's the structure, the keys here. So that you can provide it systematically, so that you have time for the hard thing, which is the talk, which is the relation building. All the other things you can systemize. And that's why we started to work with the standard. This is one study. This is a control study in patients with chronic heart failure. This is the control group. This is the person-centered care group. The intention to treat, you call it. This is all the patients that went into the intervention. And if you look at the effects of length of hospital stay, here is the mean of 9.2 days, which was Europe around roughly where they were in the hospital. And the intention to treat, so all patients that went into the study in the intervention that was a person-centered care intervention had a reduction of roughly 1 day, which was not significant. But we also have a per protocol analysis where we predefined that if you do person-centered care, the entire length of hospital stay, throughout the systematic approach, you have the per protocol analysis. And those patients that received person-centered care with the protocol had a significant 2.5 days reduction, that's a 30% reduction in length of hospital stay, and also an increased ADL, so activity of daily living, that was significant. That study, at least for me, showed that it's not enough with just one aspect of person-centered care. It's like every other therapy. You need to do it systematically. And the compliance here, if you talk about compliance, it wasn't the patient saying, no, 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 no person-centered care for me, please. It was the organization that wasn't able to do it. And I mean, I work in the organization. I know how hard it is, but that's why we need to have some structures for it. And that's why we started to work with the European standard in 2016, and it was approved in 2020. And we started it by 4 main parts: the patient's narrative and experience of illness, the partnership, the documentation and care plan, I'm from Austria, so sorry for that, and patient and public involvement in management, organization, and policy. So we also wanted to have a patient and public involvement concept that was not only bedside. All of these chapters have requirements for a standard on 2 levels, on the organizational level and on the point of care level, so in the meeting. And we also have an appendix with case description, so you have a feeling about how you could use the standard. And this is just one short overview of, this is the patient narrative with a general text about what it could be and what we talk about, the requirements, and all the requirements have then an organizational level and a point of care level. And once again, this shows what you should reach as a minimum, and the organization should then talk about how we reach it. And that is the quality improvement part of it, that you need to really talk with your colleagues about, are we reaching this one? Or is it we don't reach it because it's out of our hands? And in that sense, you have a quality improvement process ongoing. So it's not only about benchmarking care, it's also about improving care continuously. If you want to know more about person-centered care, the different studies that we've done, or also about some of the tools that we have online, please go into the GPCC homepage. And if you have any questions that you don't want to raise here in the room, then you can always email me or my colleagues. Thank you.
Please, any questions here from the audience? Do we have a microphone for the audience so we can hear the questions? Hello? Yes, okay, down there, yes. Good, any questions? You are happy to, I think you can, you can just interrupt and ask, and we're all experts in a way in this room. Thank you, Axel, for this. Now we have, this is about patient safety too. So now we have Mirka Cikkelova, and you are from the Patient Safety Foundation, and you can tell us a little bit more about your foundation first.
So hello to everyone, and thank you again for having the possibility to be part of this meeting. Just to start, yes, with presentation, a short introduction of the European Patient Safety Foundation. So we are an independent public interest foundation that is dedicated to patient safety improvement through the empowering patients and healthcare professionals. We are a multi-stakeholder organization that is based on a collaborative approach, and we are developing sustainable projects that are meant to have a long-lasting impact. We have different types of affiliates from the hospitals, national organizations, scientific societies, but also industries and patient organizations, of course. And FOKUS Patient is our dear affiliate, and that's how I'm got invited into this meeting today. And we decided to address the underlying, we are convinced that underlying problems that are causing patient safety issues that are like safety culture, leadership, teamwork, patient family involvement, healthcare worker well-being and safety, and especially the implementation challenges. As an example of our activities, so we organize annual patient safety conference, and we did the last one last year, one here in Sweden. It's always in collaboration with the local partners, because we are convinced that our organization and local partners are those who know the environment, are the best for addressing the issues in the country, and we try to bring the European perspective and then to help them raising their issues. So that's why the conference is always in collaboration with local partners. What we try to do as well is to identify issues that are common for many countries, and there we try to develop a possibility and guide how to implement the projects in different countries. Example is Fighting Fatigue Together campaign that started in UK, and we took the basic messages and then developed a European campaign that we are now getting together different countries, building the teams so that they can address the same issue with the same language, with the same kind of narrative in their own countries. And we are very proud because we received the European Health Leadership Award just last week. So the campaign starts getting a lot of attention. In addition, we also participate in different European projects and advocacy and alliances, mostly as consultants or being part of the advisory board. And we, of course, inform our members about the activities through our newsletter. Today, the question was about the checklist and standards for patient involvement, patient-centered care. So you might know this book from Atul Gawande that is addressing how such a simple thing as a checklist can improve outcomes and can improve systems even. So because it's just too easy to miss a step. So that's one of the best examples of application in practice of a checklist is the surgical safety checklist that is widely known and implemented, not often implemented as it should be, but that's the main point with the checklist and with any other guidelines, the implementation challenge. As similar as Fighting Fatigue campaign, so we identified a very interesting project that is going on in Norway. Those are the patient-own surgical safety checklists. These checklists are developed in Norway. Yes, with the anesthesiology nurses actually leading the work with Kristin Harris and Professor Arvid Senahogen. They developed surgical checklists that are for patients, and they receive them when they are planned for the surgery and when they are also discharged home after the surgery, with many questions that have been developed through them. There are, I think, 3 papers published about I can send you the presentation if you are interested, or just if you search about the checklist, you will find the papers. So it's about the development. It has been a long development for this checklist with consensus. And now, as far as I know, they are applied in 3 different hospitals, and they are collecting. There is a study about the efficiency of those checklists and the outcomes. So we are waiting for the results, and we have pleasure or we are looking forward to discuss the results of this study with Dr. Kristin Harris at our patient safety conference. And if you would like to just read a few words about her point of view, you can just visit our website where she's explaining a little bit about the project. And this interview was published at the occasion of World Patient Safety Day that was this year dedicated to elevating patient voices. So as I mentioned, what we are doing with the what we did for the Fighting Fatigue campaign, we identified this as a very interesting and potential project that could be applied on a European level. So we are now identifying needs, and what we figure out is that Patient organizations are very interested in collaboration and development of such a checklist, but only if it's in close work and close connection with hospitals, with the healthcare staff, because there is a risk of empowering patient, but not having the other side, the hospital side, prepared to receive such an empowered patient, which can create a lot of frustration for the patient side. We see the interest from the hospitals, but they definitely need guidance for implementation. So it's not the checklist the problem is the implementation part. But what we also could see that just by bringing together hospital management, leaders and patient organization, there are many questions that are being opened. And well, actually we were at the meeting and we figured out that at the end we were just sitting behind and watching. They too were discussing finally. So it was very interesting just to bring them together and to let them talk. And we also figure out that there are experts who are very motivated to help us with developments of such a checklist, maybe specify for different treatment or different diseases. So that's where we are standing now. And the main word is the collaboration. So we really need different actors to work together to make such a simple thing as a checklist for patient really work. Thank you very much for your attention. And would you like to contact me? I will be here, and just or visit our website.
Thank you. Thank you, Mirka. Can you please come up here again, Axel? So, any questions from the audience? Don't be shy. I want you to, I mean, we understood you from your presentation that it's also about that patient collaboration is also, or participation is also about patient safety. What is your take on that? Do you think, do you agree on that? Yes, please, Mirka. You can, okay. If you can just have a short.
Well, of course, the patient safety is. We can put. We have now different types of patients, and we have also well-informed patients. So if there is a part of patient safety that we can put in hands of patients, but we need to be very careful about that. We need to identify if this is the right patient to bring in more information and to more empowerment, because not everyone is ready and is able to do it. So I think there is a huge potential, but we can't do it for every patient, because there are patients that are already worried and stressed about their treatment, and they can't handle more information or even bigger empowerment. So for those, we need to design a different pathway for such a patient. So we can do it, but very carefully.
So do you mean that the participation can also be too heavy for a patient to carry?
Definitely, and that's why, well, we heard that it's again not for every occasion, but the family member can be helpful in that case. And yeah, to design the right empowerment and right pathway for the patient. Mm.
Yes.
Yeah, and I agree, and there are quite good data on that, and there is a systematic review showing that an increase in patient experience, which of course is their part is patient participation, also increases patient safety. So I think that's clearly the case. And but the interesting thing here, and there was a dissertation in Sweden looking at preference-based patient participation. It was really interesting because they showed very clearly that we as clinicians have one way of looking at patient participation, which is the decision in care. But patients have also other ways of looking at patient participation. And in that sense, it's so important that we meet. And you can only meet if we in some sort start to ask the question about, okay, how do you want to be participating in your own care? And that can go up and down, of course. But I would say that that question is so simple in itself, but so hard to do in practice. If you look at the flowchart where, once again, Norway beat us. But they are not good either, so it's sad. But I mean, we can improve, and I think that if you improve, you also improve patient safety in that sense.
Could you give us an example of where participation for the patient is some in other way in the caregiver's perspective?
So that dissertation looked at care participation from a clinician's and a patient's view in dialysis care, dialysvård. And there they showed quite good. It's also there is an instrument for it, the 4P instrument, but also with interviews you see that patients have a lot. The patient participation is about the entire care journey in that sense. Both being listened to, what happens with me next, self-care. So it's quite a flat way forward. But for clinicians, it's a hierarchy where the highest level of participation is the care decision, which of course makes sense because we talk a lot about decision in care should be divided between the patient and the professional. However, that is not. That was quite clear was not the same thing for the patient. Participation in care decision was also important, of course, but it's much about the more holistic approach to being part in my own care. It's quite weird that you even need to talk about it in that sense, but yeah.
There is also, well, I'm not a healthcare professional, but I talk a lot with different healthcare professionals and experts. So one of the issues where the patient involvement can make a big change is to inform the patient about his quality of life that will be after the intervention, where the patient, based on the risk or age or different things, might decide not to go for a treatment or not to go for some kind of operation. And that's also some kind of patient participation in decision-making about the outcomes, because maybe his quality of life will not really improve. If he's well aware about what will happen afterwards, the decision might be different.
That's a very clear example of how you can actually invite the patient to understand what is going and what question to ask maybe in that particular meeting. Do you think a list like that could be something even for the patient to bring to the healthcare giver? Maybe if you have a list of questions you should ask in this particular question, for example.
That's our intention with our next project that we are preparing, to prepare the list, the checklist for patients for different type of. We will start, or we want to start with promoting the checklist that has been developed, but then bring together different actors to develop specific checklists for specific occasions, where just give the patient the possibility to ask the right question, just to navigate the patient in this, because we don't know as a patient what to ask. So if we give the guidelines where to lead the conversation or where to search for the best kind of way in this complicated system. But I just would like to point out that the information, the high quality information, will be the key. So we need to also build kind of trusted platforms where all the information is. And patient organization, again, those are the big help because they already have a lot of information.
So, Axel, what do you think? Can the patient be invited to understand this whole standardization process too? Will we, as patient, be able to ask, do you have standards for participating for us patients, for example?
I think that, I mean, during the work with the standard, we, of course, one of the drivers were the patient organization, etc. And I get often questions by patient organization about, okay, Axel, how is it going with the standard? And when can we see the first certification of the standard? So I think that it's absolutely about the partnership. And I would say it's 50-50 between hospitals or region that ask about it and also patient organizations. So that's good.
How far are you in this work? When will we have an actual standardization for patients?
The standard is all out there, so you can use it already. So what we're looking at right now is how you could do the audit. So when you have external people coming to your clinic and where you have the discussion about which kind of how do you reach the goals of the standard, in what way, and then to have an audit about it. So we have projects about it, but you can start already now in that sense. There is accreditation also already, so organizations that would like to be the certifier of the standard can be accredited by in Sweden, and I don't know how it is in other countries. I know there is also in Norway, but yeah, so just start with it. And as I said, if there are any questions, you can please contact me if there are any further information about the standard.
Nice. I think, of course, the outcome is fantastic here, and in Sweden we are all very excited and proud of that. But the other number you gave us about the participation is really poor. How is that, you think?
Yeah. So yeah, it also it's a question about what you are asking. Yeah, and in the slide of the show, one question is about have I been enough participating in my care? So it's not about have you been participating in your care. It's that do you feel you've been enough participating? And that was quite low. So in that sense, I think that we need to increase. We have a problem right now that you on a structural level you cannot really measure it in a good way. So we right now develop some observational instruments, but also the audit, of course, in the standard to understand. Okay, where are we right now in the patient participation and patient experience level? But yeah, I think that we need to increase. The question is it? It lies on both ends, I think, and that's why it will be interesting in Sweden. Funktionsrätt, which I don't know the English word for, Funktionsrätt Sverige. Any member here looking at? They have started to implement the European patient education called EUPSF, which is one aspect, because it's also important to see how could you train the future patient researchers in order to improve healthcare. But we also need to improve our own understanding as clinicians, and that also comes back to when I educate students at the university, how do we work with patient participation. So we have a lot, we have some more things to do.
Thank you. Any questions? No? Yes, one question. Can we have, sorry, can we run? So we can get... Yes, please.
Thank you. I had a pretty serious combination of... Is it on?
Yes.
Okay. A serious combination of sepsis and then necrotizing fasciitis. So when I was released after 2 months from the hospital, I was let go pretty much like, we're going to check you in 15 days, see if you can survive out there. But then not so much happened, except that they were changing the bandages of my leg every 3rd day for 18 months. But the structure, those guidelines would have been fantastic to understand that you have now an inflammation that is actually pretty serious. If we don't care about it together, you will have a big risk of losing your leg. Maybe you will not be that precise, but something like what are the risks? And something about, because this is very important in the sepsis world here in Sweden, nobody follows up on the psychological state, the cognitive. There is a pretty heavy cognitive effect from sepsis on the brain, and that's not followed up at all. So, and of course that will influence my ability to handle my crucial leg. And as I said, it took 18 months. We finalized, but we were happy, I think. So I support exactly what you're doing. Thank you.
Thank you. Thank you for sharing. Thank you. Yes, so we do need participation, and we do need more informed patients. That's for sure. So, do you think we will? Do you think standards and checklists will actually raise the participation from the patients?
Well, I'm convinced, but it needs to be really properly done. with good collaboration and proper implementation, taking into account changes that it brings into the hospital management and processes and handling of the patient pathway. So only if well done.
Exactly, yes. And last
no, I think I agree. The most important thing is that with patient safety checklist or with person-centered care, you cannot see it as checklists, as a tick box that you need to just do, you know. So you need to have an entire ethics and the way of seeing the patient as a partner, which is the most important thing. Because otherwise, I think that because I work with those surgical checklists also, and I may be not that compliant with them either, because they become just something that you should do because you don't understand why you should do it. So I think that we have a long way to also, like you said, implement it and implement the understanding of it for both clinicians, but I think that there also patient and public involvement is really, really important to also help us to understand better, because I've never been in a meeting where you had patient public involvement, or I call it patient public involvement, so patient researchers or relatives in the same room as clinicians or board members, where the narrative or the stories become completely different. Because you get a face into what we are dealing with instead of just some checkboxes or a pinne på svenska. Good.
Yes.
Perfect.
Yes. Thank you for that. Thank you. Thank you.
Thank you.
Thank you.
Lovely audience. We will follow up on this in the next year, of course, and we are 3 minutes late now, but I'm very happy you are all here, and I will leave the stage to Pernilla, who will take over. Thank you. Hanna Brodda is my name. Thank you.
Thank you, Hanna. And thank you, Mirka and Axel, for an excellent presentation. And I think it's well connected with the next seminar or the presentation we will have. And I'm very proud, really, to bring this to Sweden. I think we have some excellent speakers, not all in presence here in our facility, but certainly online. And let's see if we can have a connection with the executive director of the patient. Let's see here, so I'm correct. Executive Director of Patient-Centered Outcomes Research Institute from the US. Nakela, very welcome to Stockholm and to our conference with FOKUS Patient. And the floor is yours, please.
Thank you so much, Pernilla, and good afternoon, everyone. I really appreciate that kind introduction, Ms. Gunther. Hopefully you can all hear me in the room. And also for this really kind invitation to be here to speak at your meeting. We're glad really to be part of the developing conversation about person-centered care in Europe, and for the opportunity to talk about PCORI, or the Patient-Centered Outcomes Research Institute's mission and the research that we fund. You know, there have been some other interactions between PCORI and our European colleagues over the years, and I understand a delegation from Sweden actually came to our annual meeting back in 2016. And while PCORI's mandate is really focused primarily on the United States, I'm sure there is so much that we can learn from each other, and I look forward to the opportunities for transatlantic dialogue. But before I begin, I just wanted to give a quick note on the terms patient-centered and person-centered. While I know these are not identical in meaning, we treat them as very close cousins at PCORI. We use the term patient-centered because it's really in our name, though person-centered is in use in the United States too, and we really acknowledge that patients are persons first, with individual preferences, needs, and abilities, and who are full partners in their care and may spend only some of their life or time in life as patients themselves. So over the next 20 minutes or so, my aim is really to introduce you to the basics of PCORI's work, including our mission, the comparative clinical effectiveness research that we fund, our unique approach to patient and stakeholder engaged health research, and our focus on dissemination and implementation, and on developing the research infrastructure for the research that we fund. And then finally, we'll take a quick look at the evolving health and healthcare landscape in the United States and the opportunities that we see for our work in the future. For those of you that may not be familiar with PCORI, we were authorized in 2010 as an act of Congress. And although we're funded by congressional appropriations and a public trust fund, we're an independent nonprofit research institute. And PCORI was founded to advance the practice of patient-centered care through the funding of research that's really focused on patient-centered outcomes. And we're the leading funder of comparative clinical effectiveness research in the United States, or we call that CER. And to date, we funded over $4 billion to more than 2,000 research and research-enabling projects. Sometimes I think the best way to understand PCORI's mission is to begin with a patient. And the patient's the most important person in a healthcare interaction. So let me ask you to just imagine a patient, one of more than the 25 million patients with asthma in the United States. And this patient has periodic asthma attacks that are sometimes severe enough to have her miss days of work or struggle to take care of her children. And she'd like to know more about the most effective approach to treating her asthma. And her competing priorities make it difficult for her to maintain a daily treatment regimen. And this kind of healthcare dilemma faces millions of people every day. There are, of course, several different treatments for asthma, but it's not always obvious which of the care options available is the best for a particular patient given their particular circumstances. And this is essentially why PCORI was created, to help fund the kind of research that provides information that helps people decide which healthcare approaches are best suited for them. So in this particular case, the relevant study is called the PREPARE study, and it was funded by PCORI, and it compared 2 asthma treatments among 1,200 African American and Hispanic adults, groups who have been disproportionately burdened by asthma but underrepresented in asthma management research studies. And the research team found that when patients used an asthma reliever or nebulizer using an inhaled corticosteroid at the same time, that in addition to the usual care, this resulted in a lower risk of severe asthma exacerbations and improved asthma control. But patients also reported improved quality of life and also reduced days from work or school that were lost compared to usual care alone. And these last 2 outcomes, improved quality of care or quality of life, as well as reduced days lost from school or work, are excellent examples of the types of patient-centered outcomes that give PCORI its name. In this study, we see a great example of the influence of patients and stakeholders in shaping the research through engagement. As the study design was being developed, patients on the research team advocated to make quality of life and days missed from work or school the study's primary outcomes. And while clinicians or academic researchers may have chosen different outcomes, these were the ones that the patients told them were most important to them. These are patient-centered outcomes. And in addition, the patient advisors also helped with ideas that enhanced recruitment as well as retention, and also helped with the diversity of the recruited study population. And so these results were ultimately published in the New England Journal of Medicine and also received considerable attention in the lay press in the United States. And asthma is just a very common condition here. And as it is in Sweden, as I understand, where the prevalence has been on the rise in recent years. So these kinds of results really provide the kind of evidence that can help large numbers of people make important decisions about their health and healthcare. And that's really our ultimate goal at PCORI, and all of the PCORI-funded research embodied really in our mission is that we want to produce and promote evidence that helps patients, caregivers, clinicians, policymakers, and others make informed decisions about what will improve care, what will improve health outcomes for individuals as well as populations. The kind of research that PCORI funds, as in that asthma example, is known as Comparative Clinical Effectiveness Research, or CER. And CER compares the benefits as well as the harms of 2 or more different approaches to prevent, diagnose, treat, or monitor a condition or improve care delivery. And it's really designed to help people make better informed decisions about their health and healthcare. It's important to note that CER compares treatments or delivery options that have already had some evidence of efficacy. And we can think of it as that next stage in the research continuum, following the discovery and the development research that leads to new prevention diagnostic or therapeutic options. So this is the kind of research that's been funded by our National Institutes of Health, that early development or discovery research. And PCORI funds the CER that has several other characteristics that are really important. CER measures benefits in real-world populations rather than the populations that are typically recruited for efficacy trials, which really tend to have narrower inclusion and exclusion criteria. And the studies that we fund typically describe results in subgroups of people, as well as informing either a clinical or policy decision. I'd like to now just zoom out a little bit to the overall strategy that guides our decisions on what kinds of studies or projects we fund. As with everything that PCORI does, the strategy was developed with extensive input from a wide array of stakeholders, including patients. And stakeholders for PCORI really includes all of the interested parties who have a stake in our research. So they include first and foremost patients, but also caregivers and families, clinicians and researchers, industry representatives, as well as hospitals, health systems, and even policymakers, amongst others. And at the core of PCORI's strategy are really 5 national priorities for health. And we consider these ambitious long-term goals that will guide PCORI's funding for the next several years. They all relate to key areas of PCORI's work, such as comparing emerging innovations with existing interventions in health, advancing the science of dissemination, implementation, and health communication. And through these current priorities, we have established over the last year or two an updated strategic plan. And they're foundational really to PCORI's mission and the reason that the Institute was first established back in 2010. The national priority, for example, on emerging innovations relates to the need that Congress saw in generating evidence on the comparative clinical effectiveness of newer innovations for particular people in particular circumstances as compared to existing interventions. And one national priority that I'll spend just a little bit more time on is the priority related to achieving health equity. The goal of achieving health equity runs amongst all of the priorities and all of PCORI's activities, but it's driven really by this continuing reality of stubborn inequities in the United States health system. And the COVID-19 pandemic really shone a light on these disparities, and though they've been present really for decades in our system. And our new strategy acknowledges the need for a greater understanding of all the drivers of health, even those that are beyond the clinical realm, such as social determinants of health, factors like where people live, the kinds of foods that they have available, the built environment like sidewalks and parks that may be available to enhance health. And on the right side of this slide, you can see this holistic approach that PCORI has that really frames our strategy and undergirds our strategy. There are 4 essential elements in this approach. The first is the funding of CER, which I've spoken about just a few minutes ago. And the second is patient and stakeholder engagement, which is the involvement of patients and others in every stage of the research process. And the third is dissemination and implementation of research results. We know that even the best research is only effective when it reaches those that it's intended to benefit. So we fund specific initiatives to disseminate study results, as well as to make sure that we promote implementation in clinical practice. And the final element is investing in the U.S. health research infrastructure, including development of a research workforce that's trained in CER, but also the support for data and technology innovations that can make research more efficient. So after funding of comparative clinical effectiveness research, the second element that I mentioned of PCORI's four-pronged holistic approach is engagement. And we define engagement as the art and science of bringing people together, representing the variety of perspectives that are needed to make research truly useful to patients, to caregivers, to clinicians, and the broader healthcare community. And you heard some examples of the effects of engagement related to the asthma study. The patient-centered outcomes of quality of life and days missed from work or school and the role of engagement in enhancing recruitment and retention of study participants is something that we see commonly in the research that we fund. PCORI requires that research teams applying for PCORI funding include in their applications a plan for engaging patients and other stakeholders, and we provide several resources for teams on how to do this. Patients and other stakeholders can participate in active and meaningful ways at every stage of the research process. And these stages include helping us to identify the areas of focus for research funding, planning the study and designing the research question, reviewing applications for funding, conducting the study and participating in the research itself, and participating in the peer review process for research results ahead of their publication on our website, and disseminating and implementing study results. And at the bottom of this slide, you can see 6 key principles that we've determined are essential to effective engagement. They include reciprocal relationships, meaning that roles and decision-making authority are defined collaboratively and clearly stated. Co-learning, meaning that all involved in the research process learn from each other's valued perspectives and experiences. And partnership and valuing all members of a multi-stakeholder research team, and trust, transparency, and honesty, which are enhanced when decisions are made inclusively and information is shared readily with all research partners. Engaging stakeholders is really not easy, and it requires significant planning as well as effort. And a key activity of building a high-functional multi-stakeholder research team that brings all individuals together with varied perspectives and interests is something that we really focus on at PCORI. And doing this requires helping people who are not trained as researchers to become more familiar with the principles of research so that they can participate fully, as well as helping members of the research team work together more effectively. And we've developed a number of resources to facilitate this purpose. And you can see these on our website at pcori.org if you're interested. They include the Research Fundamentals course to build research knowledge amongst patients and non-researchers, as well as a module on building effective multi-stakeholder research teams, and a searchable repository of tools and resources on engagement that have been used in PCORI-funded projects. Okay. The third element of PCORI's approach is building research infrastructure. And this includes both the technical tools that can make research more efficient, as well as the workforce and the delivery systems that are at the heart of patient-centered care. And in terms of technical tools, PCORI has invested in the building of PCORnet, a national network of networks that brings together high-quality data, patient partnership, and research expertise for observational and clinical trial designs that really deliver fast and trustworthy answers to advance health outcomes. And PCORnet includes more than 40 participating health systems in the United States and more than 30 million patient records available for clinical trial recruitment as well as outcomes collection. And importantly, the demographics of PCORnet are comparable to those of the United States, and more than 30 national scale studies have been conducted using PCORnet. And then that final piece of our four-pronged strategy and holistic approach is around dissemination and implementation. And PCORI is committed to ensuring that the research results from the studies that we fund reach the people they're intended to benefit. So we fund dissemination and implementation projects for a diverse array of PCORI-funded CER studies that have shown promising results. And although often grouped together, we think of dissemination and implementation related to our work to have distinct meanings. When we refer to dissemination, we're referring to activities that are designed to promote awareness of evidence to specific audiences that may have been identified as potentially benefiting from it. But when we refer to implementation, That's really when we're talking about facilitating the uptake of evidence into clinical practice through uptake into clinical guidelines and point-of-care decision-making tools. So, for instance, a CER study that PCORI funded found that patients receiving treatment for uncomplicated sickle cell disease pain crisis received better pain management and care at infusion centers as compared to emergency departments. And the implementation project that builds on these results is developing a resource toolkit to help health systems as they shift pain treatment for patients living with sickle cell disease from emergency departments to these infusion centers. And recently, we launched a groundbreaking new initiative designed to take this focus on implementation of results to the next level through leveraging the capacity of health systems to implement study results within their own systems. This is called the Health Systems Implementation Initiative, which involves 42 different participating health systems serving over 80 million unique patients across the United States. And through this initiative, each participating system is building capacity to implement PCORI-funded research study findings, and they're developing projects to implement those findings and support learning from each other along the way. A final way in which we encourage the dissemination and implementation of results is through a program that actually funds engagement awards. Some of those are designed to bring people into the research process, but some of the awards also fund the capacity of communities and patients to participate in CER, and others build capacity to disseminate results or fund projects to actively disseminate results to targeted communities, drawing on the local knowledge and trust that community organizations have often established within their communities. So in closing, I want to leave you with just a couple of thoughts regarding the future of patient-centered comparative clinical effectiveness research and patient-centered healthcare. This diagram shows what we call the virtuous cycle of evidence to implementation. And in this cycle, we can ask research questions that are of relevance to patients. We can leverage data and technology and health system or from other sources such as wearable devices, electronic health records, artificial intelligence, or even machine learning to conduct clinical CER and implementation science and to rapidly move evidence to outcome to improve patient health. In continuous virtuous cycles that integrate CER into clinical care and embed implementation into the earliest planning phases of trials so that uptake of evidence and sustainability are part of the study design, and ultimately accelerate translation and enhance impact by engaging patients as well as clinicians, health systems, and policymakers as equal partners in research. A good example of this cycle in action really was the adaptable trial. It was a study of more than 15,000 people that compared the effectiveness of two different aspirin doses in preventing heart attack and stroke. And this particular study asked questions of relevance to patients, leveraged the data and technology of PCORnet, the network of networks that I just mentioned, using a digital infrastructure as a proof of concept of the ability to conduct a trial at this scale in a digital format with electronic consents and electronic outcomes data collection, and effectively integrating clinical care and research. In this study, there was also a patient advisory group known as the adapters, and they were involved throughout the entire trial. They contributed to the study design as well as to enrollment, follow-up, analysis, and even dissemination of results. And patient engagement really is the key to these types of cycles of evidence to implementation and effective integration of clinical care and research. It really ensures that the research questions generated are those that are most relevant and important to those the research is intended to benefit. An efficient system in which clinical care and research are seamlessly integrated can help provide patients, providers, and policymakers with the evidence that they need to make informed choices, care recommendations, and policy regardless of who the patient is, where they live, or their socioeconomic status. If we think back to the patient with asthma at the beginning of this talk, we can extrapolate that example to the millions of patients who could benefit from clear, well-communicated evidence to help them make decisions on their health and healthcare. If all of us across the research and healthcare enterprise think boldly and strategically and always center on the patient or the person, I believe we can achieve this mission. So thank you again for the kind invitation to speak to all of you today, and I wish you all the best with the rest of your conference.
Thank you so much. A big hand. And I do think that we have several reasons to be in touch again, and we thank you so much and hope to meet you in person in the soon future. Thank you so much.
You're so very, very welcome, and I indeed hope to meet all of you at some point in the future. I look forward to more dialogue across the Atlantic. Take care.
Yeah, thank you. Bye.
Bye-bye.
Det här är väl ett bra exempel på också hur man kan få information och kunskap om just hur man gör på olika sätt i olika länder. Och vi kommer ju nu att gå över direkt till den här avslutande panelen. Vad har man tänkt på som mest under den här dagen? Vad har gjort mest avtryck, intryck? Ja, vi ska ta fram dem så får vi se. The final panel of the day. Jag ska försöka att stå still här nu så får vi se om jag sen inte rycker ur något. Vi ska börja med att presentera den här panelen både på svenska och engelska här får vi se då. Vi har ju Dr. Marius Gianta. We have listened to you before here today and very welcome again. Vi har Daniel Ågren. And you have a title that is the same actually in both Swedish and English. Personalized healthcare lead at Roche in Sweden. Malin Gabrielsson, she has not the same title in both English and Swedish. Regionråd i Region Västmanland. Mycket välkommen. She is the regional council of one of the Swedish 21 regions in Sweden called Västmanland, and she is an experienced healthcare politician here in Sweden. And we have also Johanna Lidén. She has also the same title, I think. It's good with life science companies. You can rely on the language. A medical head. Let's see if my English still can be used. Biopharmaceuticals business unit. Yeah? Yes. At AstraZeneca. Very welcome. And I'm so curious because we have heard and learned, hopefully, all today about patient or person-centered care and personalized medicine and all these expressions which can be used in different, both for different conditions and circumstances and society and so on. If we start with you, Daniel, if you just choose one thing, what's the most, that comes up on your mind about today?
No, but what comes up is that precision medicine is really about the patient. And I think that's what's going through the whole day. Precision medicine is a complex area. And it's really about, I think the definition of precision medicine is important to start with. And that's about gathering as much information about the patient, the individual as possible, then using that to take the right decision at the right time, And then in the third step, it's important to be able to act. And also, so you need to have access to treatment and interventions in an equal way. And then in the last phase, you need to follow up. And what is so important through this is that you need to keep the patient in focus and really focus on the patient from the early diagnostics to the follow-up. And that's when you get through precision medicine. And I think that's come through during the day.
So you're pleased?
I'm really pleased. I think this is great. And I think it's a great diversity of the presentations. And I think that's not that often you often get specific areas, or you get some really holistic meetings. But I think this is really great.
Spot on. Good. Malin, you as a political practitioner, policy maker, I mean, what have you learned from this day, from your perspective? Or learned, or just, think that this is the way to go?
I've learned that I have a lot of questions to ask.
That's good.
In order to see how far we've come, because I really don't know. I've been sitting here wondering what areas have we come far within. I guess that there are certain clinics that have come further than others. So that is some questions I will ask when I return tomorrow.
Very good.
And also we know that is the most difficult task I have, or we have as politicians, because we know that there will not be enough citizens to supply healthcare with personnel in about 10 years. So we have to find other ways to work. And there is a great possibility if we have a better partnership with our patients, I think. And
the collaboration is important here. Yeah. Okay, thank you. And Johanna, what is your point of view? What have you been thinking of this, today?
We could almost think that this was the bridge that was pre-arranged, right? But it wasn't. So my take is around collaboration. The collaboration needed to also make this happen. So throughout the latest years, there have been lots of collaboration in terms of pushing the science and making these drugs, what we represent here, available. But now it's also needed collaboration to implement and make these innovations accessible for patients in Sweden. So for me, it's the multidisciplinary totality of collaboration needed to make this go live.
Okay, thank you. And finally, in this round, Marius, what has been your best, what have you enjoyed the most to listen to or learn from?
Yes, actually, for me, it's clear that we cannot go in the same way we did in the last decades. And to your point, Malin, I fully agree that we should find different ways to deal with healthcare professional shortages, fatigue, and so on. And I think an immediate way to deal with this is actually to shift our focus from hospital-centric design of the healthcare system to prevention and early detection. I think we cannot afford as individuals, as families, societies, and economies to wait for the people to become symptomatic and then to diagnose and to spend a lot of money to treat them. Of course, it's really important, and I'm looking to you both, it's really important to see biotech innovations in terms of diagnosis and treatment, but I think we should focus on prevention and screening. And this is not something that we should start to build evidences now. Because, and I will give you just one example, on familial hypercholesterolemia, right? the evidences are around for 25 years. It's WHO recommendation to implement pediatric screening for 25 years now. And as well CDC recommendation tier 1 to use the genetics in order to identify people with FH are as well for 2 decades. But this doesn't mean that the implementation is in all the countries, and at least in Europe we have very few countries actually who have implemented pediatric screening or cascade screening and so on. That's why I think we should, you know, maybe take a step back and look to the entire picture, prevention screening, to identify what are the immediate opportunities and to start working and building new models.
So you have different, but aligned anyway. That's good, because that's really what this conference is all about today, you know, to also have different approaches to what person-centered care is. I mean, we have heard a lot of things today about to use also the words, you know, person or patient. And I think Marius can agree with, when we're out in Europe, we can sometimes hear nowadays that people are rejecting the word patient and like to have a more person-centered or person approach, I could say.
Yeah, maybe I can add to my previous comment in order to address as well your question. Because if we are moving, you know, from the current way of doing things, and the patient should be in the center, right? Moving to prevention and early detection, we are actually starting to deal with healthy individuals, if we are thinking to primary prevention, and with persons, people who are at risk. And this risk area, I may call it, is between white and black, like a gray area, is not properly addressed yet from a medical perspective, but also from the health system perspective. So, and as well for the general population, for the people, it's really tough to understand the concept of risk, and having in mind the evolution in genetics and genomics and other omics as well, I think we will be in the position to better define and stratify the risk for different diseases, and this requires a new approach at societal level as well, because people should understand, you know, what means, you know, my risk for, I don't know, for what disease. And also for the health system, and probably will need new types of expertise and new professions in the medical field in order to deal with this area, that I see it in a very close relationship with the advances in the biomedical field. When it comes to the citizen, it's a different story, and that's why I think of course, we know from public health courses that we have primary, secondary, tertiary prevention, and I think we shouldn't have campaigns for the general population to prevent something, but to promote health. And this is, again, a shift that we should probably have in mind, maybe not to go for cardiovascular disease prevention, just to give you one example, and to move to cardiovascular health.
Daniel.
Yeah, no, but I think this is a really important part to move from treating sick people to prevention. And I think, for instance, lung cancer screening is one of these areas. And I think it's a bit scary how long it takes from having evidence for the value of lung cancer screening through implementation. And that's clear in many countries, and even here in Sweden as well. So this is something that we really need to collaborate and work on in order to get lung cancer screening for high-risk patients, and we can't wait for that. So just an area to highlight.
But if we change focus or you know, change the thinking here to make it more preventable, and or we work with more with prevention overall, and then we cannot call people for patients, because they're just ordinary citizens who are in need of care sometimes, and then we're patients, aren't we? Yeah. So all of us, ordinary people, we can be just persons then? Or what should we call them? I mean, Malin, when you have the responsibility for healthcare, when are patients patients?
Well, perhaps when you need to document the diagnosis and treatment, you are a patient. But before that, you are a person. So
maybe both.
You're always a person and sometimes a patient, perhaps. I think one of the most difficult questions is about rights and obligations. It's a lot easier to talk about rights, but there are also obligations. And in order to keep your health, there are also some things that you need to do, probably. And we need to talk more about that in order to get the healthcare to be enough for all of us. And that is also a part of the person-centered care, I guess. If you have the instructions how to keep your health, but if you don't do it.
Mm. Well, the prevention and you know, public health in a way. Johanna, you are the medical head of AstraZeneca, and I guess you deal with a lot of areas. And I think as a pharma company, you also, I mean, you really deal with people's health, and I guess you keep an eye on strategies and trends in public health or the health systems and so on. So what do you think from today? What can you use as a professional in the pharma industry? I mean, what have you seen or heard today that you can go back to your colleagues at AstraZeneca and say that, well, have we really been thinking of this? Or could we think about something we've heard today?
No, I think the day has been very inspiring and I've learned a lot. One note that I took is looking into PROM more extensively than we are currently doing today, and how should we weight the more traditional outcome measures versus the PROM ones. So that's one quick take from my side. Also, since we see that if it's precision medicine is now moving into more chronic care or folksjukdomar. It has made such a difference in some of the cancers, but is now extending into other disease areas. And how can we as a company learn from other disease areas to further make the most benefit to patient outcome in the long run and across different disease areas?
I think from the introductory speeches today, we heard about both EAPO and also from OECD today about different patient surveys and patient reported outcomes and also we closed it up with Nakela L Cook from Picori, and you can see that all over the world then we are seeing results from different studies and surveys and so on, but do we really use it? I mean, that's also a question. Do we really use the reported outcomes and make it work in reality? Marius, do we really use all the good things that we have seen or?
Yeah, but probably we are at the beginning of a learning curve, because on one side we are trying to generate patient or citizen data, related data, and on the other side we should start in parallel actually to understand how to use the data in different formats and frameworks that are currently available from clinical trials, development, from regulatory processes, approval, reimbursement, and so on. What is very important is to actually to make the patients not just part of the conversation, but to start with the patients. I think this is the key. Of course, I'm a medical professional and I choose actually this career in order to, to help people. And for me, it's not. I cannot imagine another way, to start with whom? With hospitals, with doctors, doesn't make sense. So we should start with the people who actually need, patients who need most. That's why for me it makes perfectly sense to have the patients as a starting point. On the other side, we have decades of involvement, right, of the health system and all the processes and so on that actually excluded the patients. And I think wasn't possible before the digital and data revolution. Now we have actually the tools to capture what is important for patients and for their families. This is the main difference. And of course, we know that medical professionals and the medical ecosystem are really conservative. So it's not a way to to start fighting with the medical doctors because you have no chance, but to find smart ways to engage and to convince them to move things, because it's for their benefit as well. It's not for the patient benefit.
Daniel, I know you have something to say now, but I also would like to, because I was thinking, when I was listening to Marius before, that you had done a survey in Romania about the knowledge or the awareness of precision medicine. Do we have a similar survey done in Sweden? And I would also like to ask Malin, because if you want to implement precision medicine in all regions in Sweden, then Malin is one of the policymakers that can make it possible. So the knowledge among politicians must be much higher, or?
Definitely. No, but I think the level of knowledge around precision medicine needs to go up in general, because that's something that is really, if we don't know what it is, we will never work to get it implemented, and we don't have that survey. So, but
just a tip.
but I think this is something that we have been working with for many years now to increase the knowledge, because it's around patients, but it's also among healthcare professionals, because the level of knowledge around precision medicine is still not very high, and we are working with different educations and trying to improve the knowledge. And I think that's definitely one of the key pillars if we should be able to implement precision medicine in Sweden, that we need to increase the knowledge among all stakeholders, because that's when we get the engagement. And I hope I can teach you on precision medicine and the value of that, but we'll have to take that on a different occasion.
Well, you can try. But there is a strict line between how we politicians say what to do, but how to do it is not up to us to say. And I guess this is sort of in between, if it's how to do it. But it's very important for us to ask questions about when this will happen, and then also afterwards, has it happened, and what's the change, to see the results. So times like this is perfect for me as a politician to hear from all of you what is important in. But then it's also about the personnel to be able to get continuing education, which is the most difficult part at the moment when there is no time for education.
Yeah. Well-trained staff is, of course, key in healthcare. And Johanna, you are, you train your people in your company. and to see how to approach also, stakeholders and of course within your own areas what you're working with. But how do you see the need? From a company perspective, I know from my own experience as a policymaker that I have always appreciated the contact with life science industry, because I've learned a lot. Because you're actually the people who are working with a lot of innovation and so on. So how do you think we can use a day like this to spread the word about, personalized medicine, person-centered care, all the things that we have been discussing today?
So COVID learned us several things, but one is, as I see positive, is the openness to collaboration. I think that has enhanced extensively, and that several stakeholders want to come together to openly discuss challenges that we might have. So I think that's a quite good to keep up that momentum, to articulate the challenges and the tricky situation that is within a field such as this, right? So coming together as we've done today, talk about the challenges for healthcare, talking about the challenges that we might have in designing those studies, and talking about challenges in testing, etc., all the patient perspective. I think that's the key foundation in how to get the momentum going.
Thank you. And to have some closing questions to you, since our name is FOKUS Patient, is really to play with words, but everybody's talking to, about putting the patient in focus. That's really what we were trying to say when we make a choice with our name. Really, and it still is the reason, really, to put the patient in focus in a real way, to see also that the patients really can have and should have an impact on healthcare development and innovation and so on. And so, with my closing questions to you, Daniel, since you're representing right now in the panel the precision medicine, how do you think that we can, increase the impact of patients beside the big areas that are already decided for Sweden within precision medicine, which is cancer and rare diseases? How can we expand that with help of patients and really to, of course, increase the knowledge? Can we use the patient organizations in a way to do that?
No, but I think definitely, the education part is really important if we should be able to get the engagement. So it's really, we need to have patient associations that are educating, especially when we're moving into more community diseases, broader patient groups, then it's you need to be able to spread the word broadly. And I think also with the development of the digital systems, I listened to Virginia Sasso today about 1177, and I think that's really amazing that you can get these digital tools working, and then you can use the data for precision medicine. And I think that's what I saw from them was the patients, they really like it. And that's when you have patients that like a digital tool, then you get them in there and then you get the data. And I think that's precision medicine is a lot about data. We need to gather standardized and structured data throughout the whole patient journey, because then we can have this learning system so that it's actually improving for each patient that is passing through the healthcare system. And then we will have a care that's really improving continuously.
Thank you so much. Malin, how can we use the knowledge from today within within your position and the people you reach out to in your region, how can we improve the collaboration between politicians and patient organizations?
We are just starting up a senior healthcare program, similar to the national program for children's health that we have in Sweden. We're hoping it to be both standardized and individual. And I will now start asking questions about it being person-centered also. The thought is to have it person-centered. But I will start asking questions about it when I come home. And I think after listening to this day that we're on the right track with this senior healthcare program.
Thank you so much, Malin. And Johanna, how can AstraZeneca or life science companies overall make use of patient knowledge, not only for data sharing, of course, but their knowledge?
So we are appreciating all the patient input that we get to the clinical trials already now, but I will for sure after this day further articulate the importance to get even more patient feedback into the trials that we are driving in Sweden, and which is also possible in my company since we have a large R&D presence also in this country. So for sure it's going to be acted on.
Thank you so much. And Marius, from your both Romanian perspective, of course, but also since you're working a lot all over Europe, have you had a good day at first?
A very good one.
He doesn't dare to say no. So I could ask the question. No, but what have you been, thinking? Okay, this I can use for something in my work.
Yes, I have some examples. Precision health. So I really like this concept. And I like because it's coming from a group that has no previous interaction with our group. And because we contributed to a report powered by FPA last year, who actually put forward this idea of precision health. In other words, to try to address the health in a more precise way, using the digital and data and so on. So I really like this, and this is connected with what I said earlier about promoting health, not preventing the diseases. So this is, I like a lot. The second is, of course, Paolo Sparini presentation on network medicine. And those of you who will be tomorrow here will understand why. We have a project on cancer primary prevention, and we'll use the personal network analysis. So it's quite the same approach to look from a societal and individual perspective to cancer prevention. What Paolo is doing is to use network analysis in biomedical field. So I really see a very nice convergence here between the two. And third is this idea of collaboration. And having in mind this very complex environment, I think we definitely need to redefine the way we collaborate, and there are a few models, quadruple helix, pentahelix. But what I think is very, very important is to define a new model of leadership, because it's so complex that we actually need a leadership that is more distributed between different stakeholders group or inside a stakeholder group. But this actually requires trust. Because if you are coming from molecular biology, you should trust the person who is coming from AI. You don't have you should simply trust that person and trust the patient advocacy group, clinicians, industry, and of course. I think this is the way to go in such complex systems. So I give you 3 examples, very useful for my activities.
Thank you so much, and thank you to the panel. Nu så hade jag gärna haft allas era synpunkter. Kanske inte alla på en gång, men gärna om ni har några så. Vi har Mattias, min kollega, som sitter längst upp. Och vi har ett antal olika med FOKUS Patient. Nu vänder jag på ordet själv. Patientfokus, FOKUS Patient. Farligt med engelska och svenska. Tröjor på sig om ni vill lämna synpunkter eller tycka någonting så. Men vet ni vad? Att klockan 19 då är det inte en vanlig cocktail reception. At 7 o'clock, it's not an ordinary cocktail reception. Because we have invited you to a networking event. And we call it an event because you can also try your dancing shoes. We think it's good with motion. Det är nyttigt med motion, kära vänner. Ja, och man ska ha kul också. Ja, glädje, rörelse och musik och mat, det är liksom energi, eller hur? Och det är också väldigt personligt. Man kan göra det väldigt personligt här, därför att man faktiskt har naturligtvis olika musiksmak och man tycker om olika mat och allt det här. Men jag tror faktiskt att vi behöver det här allihop. Jag hoppas ni har haft en trevlig dag. Det är det första. Intressant dag, det andra. Och en givande dag när ni faktiskt har träffat kanske nya människor som ni har nätverkat med. Men klockan 7 så får ni en ny chans. Som sagt. Och jag utlovar lite glitter och lite glamour. Så ni som har anmält er, who have registered for the networking event at 7 o'clock. You're very, very welcome. Bring on your dancing shoes. Bring on your energy. And we hope to have really glammy event tonight. Because we do believe that patient organizations together with companies, industry associations, whatever you come from, really deserves to have some fun together. What do you think? Can we do it? Yeah. Thank you for today. Thank you.